Welcome back to Mostly True Psychiatry with me, Dr. Mellon. We're on our last video for this part of the series for anxiety disorders. We've done first line, second line. Now we're working on the PRNs, or the kind of that acute management when you do a little bit of polypharmacy at the beginning just to put out the fire. Here are half a dozen drugs you need to get familiar and used to and comfortable with. All 6 of these. You'll use them all the time. I'll start with buspirone. So buspirone is a drug that needs to be given scheduled, not PRN. It'll be the only one on this list that's that way. It's one that you give twice a day. It's not going to sedate people. It's not going to make them like foggy feeling. Typically you just start with 7.5 milligram tablets, then you go up to 15 milligrams, and then you go up to 30 milligrams twice a day. So up to 60 milligrams total in a day. The ideal patient, the one it probably has particularly awesome benefits for, is alcohol use disorder. So if I type in like buspirone, alcohol use disorder, they've done a bunch of studies on this. They've been double-blind, placebo-controlled trials. They've showed reductions both in anxiety. They show reductions in alcohol consumption, and they show that the person's more likely to stick with the treatment versus when you give them other things for anxiety when they have alcohol use disorder as well. And that's because they could switch it over to placebo, and then if the person was started drinking again or doing things, that's how they compared it. But it's actually a lower dose, so only up to 40 milligrams total a day. So if they have alcohol use disorder as with it, tell them about the benefits it's going to do for their drinking, make it easier. There's other treatments as well you can do to help them out, but that is a perfectly good one. I'm having a hard time finding. This needs to go to treatment. There we go. So there's buspirone. Bad patient is supposed to be benzos previously because it's really just the acute phase. Any drug you give after a person's been using benzos a lot for months or years is going to seem like a crappy drug. Why it sucks, I guess BID dosing, I don't know. Not too much bad with it. Quetiapine, immediate release. So this is great for sedating an over-anxious patient. You're going to use lots of euphemisms, but it's sedation. Typically, most people could probably handle 50 milligrams if you start that at night, like one at night, and then the next day they can use it once earlier in the day and, kind of just slowly jerry-rig it up. Super sensitive, you say 12.5 milligrams. I guess if you want it to be like Benadryl, you give 25 milligram tablets, it's fine. You can increase it 50 to 100 milligrams daily up to a max dose of 300. At 300, it's going to cause people to get fat. So I'd be really hesitant to go over 100, 150 in a day personally. Not good for geriatric patients. It's got too many receptors it hits. It's a fall risk. It's all sorts of stuff. But 25 milligrams a few times. Just kind of think of it as another version of Benadryl that you're giving, like hydroxyzine would be. Gabapentin and pregabalin. So they're basically the same drug. Pregabalin, kind of a Me Too drug. Pregabalin gets the difficulty of being under as a scheduled drug, as a drug of abuse in most states, including the state of Texas, maybe all states, I don't know. Gabapentin doesn't always have that requirement, so it's easier to prescribe. Gabapentin is more sedating than pregabalin, so the side effects typically are worse. But everybody's super different. You're going to have some people you put on a low, medium dose and they're super sedated. Other people are at max dose and it's fine. So you can just try it out. I wouldn't worry about that too much, that side effect. Gabapentin, you have two treatment strategies. Either you just say 100 milligrams 3 times a day, see how they do. Another option is you just really want to help them with sleep first. You start with maybe 300 milligrams at night or something to see if it helps them sleep. And then if it does, you get out 100 milligrams during the day once or twice. And you can just keep going up as far as you want. It's a lot of like messing with the drug, which is obnoxious. Too many changes and steps. You can go up 100 milligrams at a time, trying to get to 300 milligrams 3 times a day, really, because it's cheaper and they sell them in 300 milligram tablets. And it's actually, pregabalin and gabapentin are actually pretty expensive. I've tried pricing them just for cash cost and stuff, and gabapentin, I think it's like $60 pretty easily, so it's not cheap. They both help for neuropathy, which is awesome. So anybody has like chronic pain, pregabalin and Lyrica is commonly given for that kind of back pain. that are by pain specialists. If they have a drug history, pregabalin's not great. Renal impairment's a problem for gabapentin. I bet it is for pregabalin too. If I say pregabalin. Yeah, renal adjustment on both, so I'll correct that chart. Because they're the same drug, right? If one looks different, you got to figure out, wait, why? So they give you lots of room to play with. That if you want to be able to do that, and it's part of the interaction, it's the doctor-patient relationship, then yeah, fine. You go from 100 milligrams. For gabapentin, you go all the way up to 800 milligrams TID, and then pregabalin starts at 150 at night, and then you keep adding 150 milligram increments up to 300 milligrams twice a day. Typically, would be an upper end. Propranolol. I want to check one thing because I've misspelled this word for ever. Yes, there is an R. That's what it is. I used to call it propranolol because IR genius. So it's a blood pressure medication. It's really different than the other ones. The other ones are sedating. Propranolol is something that's more likely to be helpful for a person who has a lot of somatic symptoms. So they're tremor, flushing, sweaty, chest tightness, that kind of thing, where they get all worked up in their body. They start having a lot of just legit autonomic nervous system activation for the fight or flight system. And so it should help with that those symptoms. There's not a lot of logic on why it would help central nervous system. So it's probably mostly just people are very somatic, where they notice all their body feelings and sensations, and it's distressing to them. And this is a way to knock it out. Performance anxiety being a specific kind of way that it helps people, like they're having to go up in front of people and they're getting all anxious. You can typically start at 10 milligrams BID or PRN or whatever you want to do. And it can go up to 20 milligrams twice a day. I've seen as high as 20 milligrams 3 times a day or 30 milligrams twice. The risk is, as you go up with a blood pressure medication, it's a blood pressure medication. So, it's hypertension fall risk. So it's bad for geriatric. It's a non-selective. Let me just make sure I don't say this wrong. So it's a non-selective, beta 1 and beta 2 antagonist, which means it affects your lungs as well. So it's not good for COPD folks, asthma. You're going to mess up all their meds. You're going to cause a ton of problems. So do not get propranolol if they have hypertension, COPD, asthma, or they're old. And it's not a good drug. So it actually becomes fairly limited because of those issues. And then hydroxyzine is an old school Benadryl. I honestly would guess that hydroxyzine is something like quetiapine, when quetiapine is at 12 to 25 milligrams. It is an H1 receptor agonist. So the hydroxyzine, they come in 3 different sizes. Usually it's 12.5, 25, and 50 milligram tablets. If they're frail, really afraid of side effects, you go all the way down to 12.5. Basically, just give everybody 25 milligrams tablets. Other than that, and you can increase it once if you need to 50 milligram tablets. I've seen people try to give as high as 100. I don't really. It's unlikely to me that means anything. That if you want to play with drugs that much and push them around, then play with gabapentin for the patient. Because hydroxyzine is really old school Benadryl, right? All right. Hopefully that was helpful. So that gives you half a dozen reasonable drugs to give to people. PRN. You should learn some alternate names for these, because when you're inpatient or doing things, people will know one drug and I won't take hydroxyzine, but they'll take Vistaril or they'll take Atarax. So you just switch names. It's all fine. Because a lot of this is window dressing at times. Really, they need a proper SSRI, SNRI, and they need therapy or whatever else the other issues. All right. This has been Mostly True Psychiatry with me, Dr. Mellon. Next series we're going to go over will be bipolar mood disorder type 1. All right. Cheers.